Okay, let's talk about restrictive lung disease. So restricted lung diseases may lead to decrease in lung volumes, decrease in the FVC to and TLC. PFTs are normal, but in very high yield, guys. This thing is like just bury in the mind that you have increase in FEV1 to FVC ratio. You will have normal or increased in FEV1 to FVC ratio. If you see that anywhere, you're just gonna think about restrictive lung diseases. Okay, um, and if you have see, so if you see again, if you see you have a normal or increase in FEV1 to FVC ratio, it's restrictive. If you see there is anything decreased in these values, you're gonna think about obstructive right away. I mean, you see it, you right away think about these two diseases. Okay, so now let's look at the patients may present with short, shallow breathing. Okay, types are altered respiratory mechanisms. That's one of the type. This is extrapulmonary. You have a normal DLCO in this case. You have a normal AA gradient. Okay, um, you have respiratory muscle weakness basically. In which case, where will you have respiratory muscle weakness? Polio, myasthenia gravis, Guillain-Barré syndrome, ALS. And the other one is chest wall abnormalities. Where would you have that? In scoliosis, severe obesity. So again, if we just read what we talked about, we said respiratory mechanism. There's an altered respiratory mechanisms. In altered respiratory mechanisms, which is extrapulmonary, is something which is respiratory muscle weakness or chest wall weakness. Okay, that's the one of the types. The other type is diffuse parenchymal lung disease, also called interstitial lung disease. Interstitial lung disease is what? Pulmonary cause. There's going to be decrease in DLCO. That's in comparison with your normal DLCO and a normal AA gradient. But here you just have increase in AA gradient. Okay, pneumoconiosis. Diffuse parenchymal lung injury, like called interstitial lung diseases. What are the diseases in it? You can have interstitial lung disease with the pneumoconiosis, which are your coal workers, pneumoconiosis, silicosis, asbestosis. You can have sarcoidosis, which is basically bilateral hilar lymphadenopathy, non-caseating granuloma, increase in ACE and calcium levels, idiopathic pulmonary fibrosis, granulomatosis with polyangiitis, pulmonary Langerhans cell histiocytosis, which is eosinophilic granuloma, hypersensitivity pneumonitis, drug toxicity like, for example, bleomycin, busulfan, amiodarone, methotrexate. So all it is a BAM. BAM, right? So BAM is what? B2 B2 BAM, or you can just call it BBAM BAM. What is BAM? Bleomycin, busulfan, amiodarone, and methotrexate. And these are all drug toxicities which cause the parenchymal lung disease or interstitial lung disease. Then the last one is acute respiratory distress syndrome, which also causes all of that. Now, the other thing that is very high yield is radiation-induced lung injuries, also causing parenchymal lung disease, in which it is associated with pro-inflammatory cytokine release, in which you have TNF-alpha, IL-1, IL-6, right? TNF-alpha, IL-1, IL-6 may be asymptomatic, but most common symptoms are dry cough and dyspnea, low-grade fever, acute radiation pneumonitis. Develops within very high yield. This is important. So acute one will develop 3 to 12 weeks. Within 3 to 12 weeks of radiation, which is called exudative phase. But radiation fibrosis can develop after 6 to 12 months. So acute radiation pneumonitis, meaning inflammation, will occur within 3 to 12 weeks, which is the exudative phase. But the fibrosis will eventually occur months after the radiation. Months after the radiation. Okay, so I mean, this is all just memory based, guys. I mean, got nothing here, just memory. But what's different is if you have some restrictive lung disease, how you gonna know? You're gonna know that by right here, increase or normal FEV1 to FEC ratio, and you see normal DLC or normal A gradient, you think about extrapulmonary. But if the DLC is decreased and there's an increase in AA gradient, you think about pulmonary disease. What are the pulmonary diseases? Pneumoconiosis, sarcoidosis, idiopathic granulomatosis, pulmonary Langerhans histiocytosis, hypersensitivity, drug toxicity. What are the drugs? BAM. BAM is the drug toxicity. Acute respiratory distress syndrome. And your radiation induced. Radiation, what is radiation going to do? Well, radiation is going to cause a release of the pro-inflammatory cytokines. That radiation that you give is going to release the cytokines. Which cytokines? Nothing extra here. TNF alpha, IL-1 and IL-6. Right? Radiation, TNF alpha, 1 and 6. Yeah. So that's how can we memorize that? So radiation, right? Radiation. Okay, A1 and R is like 6. TNF alpha for A alpha. I mean, just remember A1 radiation. You know, when you want to have a radiation, you want to go to a good place for radiation, right? You want to go to some nice CT scan place, some nice X-ray. You say, hey, I want to look at some good technology. So A1 place for radiation. So TNF alpha is from A. TNF alpha plus your IL-1, A1, and your radiation is for 6. I mean, this is one of the things. If you have a better one, please drop it down in the comment section. You know, I would love to see it. But okay, so we got the BAM here, and we got this TNF alpha and IL-6. It could be asymptomatic, but again, it's just going to present a dry cough, nothing else, with a low-grade fever. Dry cough, low-grade fever after radiation. You think about pneumonitis, which can occur within 3 to 12 weeks, but the fibrosis will occur within 6 to 12 months. Moving on with the specific one, which is idiopathic pulmonary fibrosis, IPF, idiopathic pulmonary fibrosis. Okay, let's look at this one. It is a progressive fibrotic lung disease of unknown etiology. Amazing, unknown etiology. You know, that's a good thing. So we don't have to memorize more. It's just unknown. But let's see. Involves multiple cycles. Okay, multiple cycles of the lung injury. There's inflammation. There's fibrosis. Lung injury. So many cycles of lung injury. Persistent lung injury. Multiple lung injuries with inflammation and fibrosis causes fibrosis. That's a simple thing, right? Idiopathic, we don't know the cause. Pulmonary is talking about lungs. Fibrosis, lung have been fibrosed. No rocket science here. Associated with somebody who's tobacco smoking. Anything, just put it on tobacco. Anything, put it on tobacco smoking. Okay, environmental pollutants, genetic defects. What are the findings? You have progressive dyspnea, fatigue, non-productive cough. You have you have fibrosis. Why would you have a productive cough here? I mean, look, you have fibrosis. You don't have any productive cough, man. Crackles, clubbing important. Imaging will show peripheral reticular opacities, important. Okay, with traction bronchiectasis. Traction bronchiectasis plus minus honeycomb appearance of the lung. Within the advanced honeycomb appearance is simple. You know, you just have all these small small appearance of like a honeycomb appearance, meaning small lung fibrosis that you think and you say it's a honeycomb appearance, okay, of the lung, which is seen only in advanced disease, by the way. Histologic pattern is usually interstitial pneumonia with decrease in type 1 pneumocytes. What were the type 1 pneumocytes? They were covering 97% of the alveoli. They were the squamous cells, right? It would line the whole alveoli, and in them they had the type 2 pneumocytes. with some macrophages, right? Increase in type 2, important. There's increase in type 2. Why? Because type 2 are the stem cells. So when there's so much destruction in type 1, type 2 are like, hey, we can't leave our brother here. We got to help him out. So type 2, the bigger brother, 2 is the bigger brother, right? So he's going to come and he's going to try to help. And he's just going to increase himself because this is a stem cell. It's going to try to produce type 1 pneumatocytes. Okay. And you have increase in fibroblasts. Fibroblast, fibrosis. Where you see fibroblast, fibrosis. Okay. Complications of this pulmonary fibrosis or pulmonary hypertension. For sure, you have a fibrosis. You're going to have hypertension, right? Because it's really hard for the it gets really hard to pump, and those pulmonary arteries, they thicken up and cause hypertension. Right heart failure, because it's so hard to pump in there that this guy's gonna fail. Right heart failure, remember? And it's gonna cause arrhythmia, coronary artery disease, respiratory failure, lung cancer. Okay. Okay, so let's just recall the whole thing and see if we have anything important. Okay, this is very high yield that you have low type 1, increase in type 2, and increase in fibroblasts. So when you have this persistent inflammation, right, that you're going to release some cytokines. What cytokines are you going to release? TGF beta. You're going to also release prostaglandin growth factor, fibroblast growth factor, and you're going to release vascular endothelial growth factor. So why am I writing all that? Because for the treatment purposes, we will give each one of them, we will try to inhibit that. So we will inhibit this TGF beta by giving the drug known as I'm going to write here PIR, perfenidone. What is perfenidone? It is an inhibitor of TGF beta. It is basically anti-fibrotic. So this guy was causing fibrosis. We give perfenidone, which is anti-fibrotic. That's one thing. And all the other ones, these right here, PDGF, FGF, VEGF, these ones, they will be inhibited by, let me write the drug so you can write too. So it is the is it Nintendo? Nintedanib, I guess. Nintendamib. Let me write Nintendamib or something like this. Okay, I'll make sure what it is, and then I can send it to you if you guys have any question on this one. Okay, so what is this going to do? This is just going to inhibit all of these other factors. And why are we giving this drug anyways, right? Because this drug will slow the progression of fibrosis. It's just going to slow the progression, slows the progression of fibrosis. And how would it slow the progression? With all of these factors, what are they going to cause? Well, all of these factors are going to cause increase in fibroblastic activity, one thing, collagen production, second thing, and myofibroblast formation. These all things eventually will cause pulmonary fibrosis, and we're trying to stop that, right? We're trying to stop that by giving this drug which is called Nintendamib or something, and I will look into that and tell you what it is specifically. Okay, so this is high yield and important one. Okay. Other than this, yeah, so that's pretty much all for idiopathic pulmonary fibrosis, which is summary, which is basically progressive lung disease without any cause, because of there is a persistent lung injury, inflammation, fibrosis. Okay. And you just have on the periphery, you will have reticular opacities, honeycomb appearance in advanced diseases. Interstitial pneumonia will be there. Importantly, decreased type 1, increased type 2, and increased fibroblast. Complication, high yield. Pulmonary hypertension, right heart failure, arrhythmia, coronary artery disease, respiratory failure, lung failure, fibrosis. Okay, now the next one is hypersensitivity pneumonitis. Hypersensitivity as you can see with the name, and pneumonitis inflammation. It is a mixed type 2 hypersensitivity. Which hypersensitivity? Type 2 and 3. 2, 3, no, I mean, my bad, 3 and 4. 3, 4 hypersensitivity reaction to environmental antigens such as thermophilic, actinomyces, and aspergillus, often seen in farmers and bird fanciers. Where? Farmer, bird fanciers. Acutely, it can cause dyspnea, cough, chest tightness, fever, headache, often self-limited. If stimulus is removed, chronically leads to irreversible fibrosis with non-cascading granulomas, alveolar septal thickening, traction bronchiectasis. Okay, so again, what is all this about? This is all about that you have so much destruction that it causes thickening, non-cascading granuloma, with type 3 and type 4 hypersensitivity reaction, right, with the birds. So important thing in the history, you have farmer, the bird, the person who has the birds, that can develop all of these. So they will ask you what sort of cells are in type 2, type 3, type 4 hypersensitivity reaction, which are causing all this damage. They are your increase in CD8 positive T cells, cytotoxic positive T cells are increased high yield point, and that causes lymphocytic infiltration plus so lymphocytic infiltration plus non-caseating granuloma and alveolar septal fibrosis with traction bronchiectasis, you're going to call hypersensitivity pneumonitis.